We would like to start with our first session post-lunch, which is titled VTE Persistence of Risk and Extending Therapy, Review Evidence and Translate to Practice, which is led by Dr. Robbie K. George. Robbie K. George. Let's give a big hand. Thank you. Thank you so much. Welcome, sir. The stage is all yours.
Thanks. Thank you. So I think we're probably between lunch and that's always a challenge, isn't it? Anyway, so we're going to be talking today about VT recurrence, the risk, and how you manage venous thromboembolism. You know, this is a hall which has got vascular surgeons, people who are into venous practice. So I'm sure most of this is not a surprise to them, and most of this is not new. I don't think anyone in this audience really would doubt the fact that VT is a major cause of morbidity and mortality. We don't have figures for India for estimates, but certainly for Europe, more than 370,000 deaths each year. That's huge. The mode of death typically is a pulmonary embolism. The DVT is the preliminary event, which then results in a pulmonary embolism, which is a significant fatality rate for a massive PE. And you know the presentation, this, chest pain, dyspnea, shortness of breath, a sudden drop in blood pressure, all of that. And that is the acute event you need to manage. So the first step when you get a PE or a DVT is how are you going to deal with it? And that's what we will be touching about. This is just a background of why DVT, VT matters. It has a huge global burden. The incidence of about 0.8 to 2.7 per thousand is a big number. Half the patients who get a DVT will also get a PE, but the majority will not, of course, be a clinically significant or a large PE. We've just come through a pandemic, and every surgeon here will have encountered enough of COVID-associated thrombosis. It was seen in the lungs, but we also know COVID-associated thrombosis has affected other vascular beds as well. And it is down to all of us to be involved in this treatment and to knowing what to do with them. So why do patients develop VTE? So there are risk factors which predispose you to that, and there are others which expose you to that. So this is an interesting way of dividing up the risk factors. So predisposing is something which you had prior to the event, such as a history of VT. If you're older, heart failure, you've got varicose veins, you're big, obese, immobile, if you had a stroke, if you got an inherited or an acquired thrombophilia, and remember there's both inherited and acquired. For instance, the COVID-associated thing was an acquired thrombophilia, while if you got a protein C or a protein S deficiency, that's an inherited one. If you've been on hormones such as the oral contraceptive pill, if you have renal insufficiency, which a lot of us treat, your patient is straight away more prone to a DVT. If you have any of these, and in addition to that, or even without having one of those, you get exposed to additional risk factor like surgery, major trauma, major acute medical illness, heart failure, respiratory failure, all of these things predispose you to getting a first event of a DVT or PE or a recurrence. Cancers and inflammatory diseases like ulcerative colitis, rheumatoid arthritis, they remain in the background and keep your risk elevated all through. So NOACs, or the novel oral anticoagulants, have been well validated for efficacy for the treatment of VTE. So there are a few drug classes which have such good quality evidence. One of the ones is, of course, statins and antihypertensives, but I think after that, if you look at it, the anticoagulants probably have excellent evidence for efficacy. So you've got the Amplify, the Einstein trials, the Hokusai, the Recover trials, which each of them are looking at the 4 molecules which are commonly used for anticoagulation. And they all were comparing that particular NOAC against the vitamin K antagonist, which had been the gold standard for donkeys. And all of these trials were looking for a non-inferiority. So that means the drug that was being tested to see whether it's at least as efficacious as the original gold standard. And across the board, even when you combine all of these, you will find that there is a clear-cut lack of, that the efficacy is at least equivalent, if not better. So whenever you're looking at any anticoagulant, what's the trade-off? Are you going to have your patients bleeding out to death? So you really want to make sure that your drug is not causing a bleeding problem. Again, when you look at these trials, which again were looking for non-inferiority, you are clearly seeing a significant benefit in favor of the novel oral anticoagulants with a significantly lesser bleeding rate with them than with the vitamin K antagonists. And this, of course, does not even take into account the fact that in our country, vitamin K antagonists with INR monitoring and all is very difficult to keep patients into their therapeutic range. So if you look at the anticoagulation treatment approaches, so the conventional treatment is the initial 5 to 7 days, patients are either on unfractionated heparin or low molecular weight heparin, following which there's a period of bridging, because as you know, the vitamin K antagonist will cause the patient to become prothrombotic for a few days while you initiate it, following which they go on to long-term treatment. And this is with VKs at the target INR of 2 to 3 years. The duration, of course, is another thing to debate. While with the other molecules, with the NOACs, for dabigatran and edoxaban, there is an initial treatment phase of 5 days with low molecular weight heparin. This was based upon the trials, followed by dabigatran or edoxaban in a BID dosage for dabigatran. With a single drug, you can avoid this preliminary phase and you can go directly to using rivaroxaban or apixaban. Like with all DVTs, the first 3 weeks, you typically want to treat more intensively because the patient is felt to be in a more prothrombotic state at that time, which is why the dose for rivaroxaban would be 15 milligrams twice a day for 3 weeks, after which you drop it down to 20 milligrams once a day in continuation. And similarly for apixaban, it's 10 milligrams twice a day for a week, followed by 5 milligrams twice a day. And that also brings you into the option of following a maintenance therapy, which will vary between 3 to 6 months. You will want to take a decision regarding whether you want to extend DVT treatment, who are the candidates for extension, and what dose should you give them. So is it rivaroxaban 10 or 20, or is it apixaban 2.5 twice a day? So the rivaroxaban Einstein phase 3 study design basically looked at all the patients who were part of Einstein DVT and Einstein PE. That's the ones who had the preliminary treatment as part of the non-inferiority studies in comparison with vitamin K antagonists. And then they were included into the Einstein extension study, where these people had completed their initial treatment for 6 to 12 months, following which they went on to rivaroxaban. So when you look at efficacy over there, you're showing that there is similar efficacy with lower risk of major bleeding when you compare it to enoxaparin or vitamin K antagonists, both of them. Now, this risk of bleeding is not huge, but this is talking about major bleeding. This is not talking about a bleed from your tooth or something of that sort. This is about major bleeding, which requires blood transfusions, admission to hospital, or associated with hypertension. So there is a significant difference when you're treating a large number of patients across a period of time. So the general feeling we have is if you have a frail patient. So who's a frail patient? Somebody who is more than 75, weight of less than 50 kgs, who has got a low creatinine clearance of less than 50. This kind of group we've always felt is likely to be more at risk of bleeding, more at risk of complications. But surprisingly, if you look at the data, frail patients actually do better with a NOAC than a vitamin K antagonist as compared to the regular patient. So if you look at this chart here, so in the non-frail, the difference between the major bleeding between the non-frail and the frail is huge. So if you're a frail patient, the risk of bleeding with a VK or enoxaparin is significantly more than if you use a NOAC. So this almost runs contrary to what we tend to think. What about for patients with renal impairment with fewer major bleeding events? Again, for mild and moderate renal impairment, so this is not for severe renal impairment because rivaroxaban does get metabolized and excreted through the kidneys. Rivaroxaban is actually safer to use as an anticoagulant than enoxaparin or VKs. So I think we're all kind of very comfortable with the initial management of DVT-VT. The problem is how long should you anticoagulate them for? When do you stop? Who do you want to continue it for? So yesterday, Dr. Sukesh and Dr. Pratap gave 2 excellent talks on this very topic, and I think there is no single answer that fits everyone. The one message I get from both of them and discussing with our hematologists as well is that the so-called thrombophilia workup is probably not very relevant in day-to-day clinical practice in deciding what you do. It is the patient profile that tells you whether or not they need it. So why is this relevant? Why do you want to continue it for a long term? It's because there is a high risk of a recurrent VT after discontinuing anticoagulation. So if you look at the recurrence at 10 years, 40% of your patients have had a VTE at 10 years if you've not continued anticoagulation. That is very significant. And in the initial 6 months itself is about 5 to 6%. This is where a NOAC becomes very attractive. You don't require monitoring, you don't require injections, it's just a pill that you pop regularly. The question is, do you need it and what dose do you need? So looking at the evidence, the European Society of Cardiology 2019 PE guidelines categorize risk factors based upon, you stratify patients into how likely are you to get a recurrent VT. So those who have a low risk of recurrence, that is less than 3% per year, is someone who had a major risk factor, which was for a time-limited period. So let's say you had a major surgery, you had a major accident, and you got a DVT after that. It's very unlikely you're going to get another DVT. Okay? So this is for a patient who had a significant associated transient risk factor. And they've given examples on the side and the column there. So your intermediate risk group is where there's a 3 to 8% risk of recurrent DVT per year, which is not insignificant. So this is for patients who had a transient or reversible minor risk factor. So this is a subgroup who got a DVT without too much provocation. That means they are probably prone to getting DVTs in general. So this is someone who had a short GA, someone who had a hospital for a few days, for just a three days admission, someone who's on a pill, somebody who had pregnancy-associated DVT, or someone who had a long-haul flight. So these are all relatively minor provoking factors, but in this particular individual, they were enough to provoke a DVT-PE, which means this patient has a higher risk of getting a DVT-PE in the future as well. And the highest group is those who had a classic unprovoked DVT, those who have an active cancer, or those who have APLA. So if you look at this, most of your other thrombophilias don't come into the high-risk group. APLA does, as does an unprovoked DVT. So in general, even if you look at this, it will show you that there's really not much of a role for routine thrombophilia testing for protein C, protein S, prothrombin G mutation, etc. So what do you do? How do you treat them? So the Einstein extension and Einstein choice pooled analysis basically was looking at the recurrence rates in patients who were on a placebo or aspirin versus rivaroxaban. And you can see the significant difference. So those who were on rivaroxaban had an extremely low recurrence rate of 2% at 1 year as compared to 10% for those who were on a placebo, or in Einstein choice where there were patients who were on aspirin who had a 6% risk of DVT. And when you look at this, even in those who have a minor risk factor, if you look at it, the recurrence rate, if you don't take anything, is 10.7%. That's significant. While if you have a minor transient risk factor, the risk is about 4.2. So if you've got a minor persistent risk factor or you have an unprovoked DVT, you are someone who has a 10% annual risk of DVT recurrence each year if you do not take treatment. Again, the question is it safe to use this for a long term? And what you find is that the bleeding rates are similar with rivaroxaban when compared to aspirin or a placebo. Not much of a difference whether you take it or not. So that means the drug is actually safe in terms of bleeding outcomes. And the previous data suggests it is effective in terms of preventing a DVT and PE. So the key message that I would say is that whenever you've got a patient who is coming to the end of their standard maintenance period of DVT treatment, you need to take a conscious call that do I need to continue anticoagulation for this patient or not. So someone who is a young male, who's had an unprovoked DVT, who had a proximal DVT or a PE, is someone who is very high risk for getting a future significant VT event. Such a patient, irrespective of what your thrombophilia workup shows or does not show, is someone who probably should be considered strongly for long-term anticoagulation. You get a woman who has a DVT associated with a pregnancy and has got no other ongoing issues. She probably does not require a ongoing long-term VT treatment. So a lot of the decision-making is actually clinical, but this is an active decision that is to be made. And if you do choose to continue the drug, it is perfectly sensible to consider rivaroxaban as a long-term option over there, because it does show that you have a safe way of reducing your DVT-VTE risk. And these are the simplified ESC guidelines, which basically just talk about the same thing. You look at your patient, did they have a major transient provoking event, or did they have a persistent provoking event, or was it somewhere in between? If they have any of the latter three categories, you do want to consider extended anticoagulation. If you think someone is at a high risk for a bleed, you may choose not to do that, but that's a clinical decision. Thank you, and I'll be happy to take any questions if there are.
Excellent talk, sir. Sir, one clarification is, certain patients like aplath positive who require lifelong anticoagulants, triple positive, right? So do you prefer Novax or VKA? Because we don't have safety profile of these Novax for such a long extended duration.
So yeah, good question. Actually, there is a recent trial which suggested VKAs are more effective than NOACs in APLA syndrome. So in that patient group, that's the one subgroup where you would consider VKAs in the long term. But VKAs in the long term also have their own problems. You know, for women, you get osteoporosis, you get bony issues. So there are other issues with VKAs also in the long term. Regarding the long-term duration of NOAC usage, you're right. We don't really have, 50 years experience. But they have been around for more than 20, 25 years. And so far, certainly, there's not been any signals to suggest that there are issues with long-term use. But that's, of course, something that will need to be kept an eye on. Dr. Bedi.
Yeah, thank you, Robbie. Just a question that considering the experience we have today with NOACs, why is it that with the rivaroxaban we don't start with the heparin, but with dabigatran we do? Because we know that the onset of action is, everything is almost similar. So what is the rationale for that?
So I think this is a reflection of how the trials were designed. So the dabigatran trials were designed with a 5-day lead-in period because that was the protocol at the time in terms of dealing with VKs, while the rivaroxaban trials were ready to be designed starting with day 0. And once they've got trial data which suggests this is the licensing, I don't think dabigatran can really turn that around to say we are okay to go from day 0. If you ask me, do I think dabigatran can be used from day 0? Most likely it can, and we do use it from day 0 also. But with rivaroxaban, you have clinical data, trial data to suggest, licensing data to suggest you're perfectly fine to go with it from day 0. And the other point, of course, is all of us feel that the initial few days of an acute DVT is when the patient is most prothrombotic, most likely to have an extension. And there is and I'm sure you've seen this, a lot of people, the tradition is that you put the patient onto heparin infusion. That's been the custom for many, many years. For others, it is you have to put them on low molecular weight heparin for a week. And there's nothing to suggest any of those techniques are completely wrong. But if scientifically you want to put a patient onto rivaroxaban or apixaban from day 1, you have the science to back you up on that.
So when you do use dabigatran, do you use it in a higher dose for the first 5 days?
Do I use it?
You said sometimes you use it from day 0.
Yeah.
Would you use it at 150 or would you give a higher dose of 5 days?
No, 150 BD. Yeah.
Let's give a big hand to Dr. Robbie K. George. I would now request Dr. V. Balaji to speak on the topic, treating CAT patients today. What do the latest evidence and guidelines say? Over to you, sir.
Good afternoon to everybody. The outset, let me thank the organizing secretaries, Dr. Deepak Salraj especially, who has extended his invitation to give my presentation today. Dr. Robbie George has given a presentation about the usage of this molecule, rivaroxaban, on a wider extent in the form of using this as a molecule in the treatment of DVT-PE. What we are going to talk about is a specific subgroup of patients. He also mentioned about cancer as one of the very strong risk factors for recurrence, and that is what we're going to concentrate on today. Also, the topic says clearly, what is the latest evidence and guidelines say? Treating the patients today. Why do we mention today? Because there's so much is happening. So much of advancements are happening in the understanding of the disease. So much of advancement happened in the development of molecules also. So if we are using a molecule the treatment and prevention of the disease, we should know how, why, and which one to choose, which is the right molecule for the treatment and prevention of this CAT. As you know, this phenomenon is been understood for many, many years. In fact, we all know that Troisier's phenomenon, described by Armand Troisier, who is a very excellent, smart physician from, French physician from Paris, who was involved in very many medical, clinical understandings, especially in this so-called the cancer-associated thrombosis. He was talking about accelerated platelet activation, also about so-called the fibrin activation, but he never understood the whole spectrum of the etiopathogenesis of CAT. However, when he retired in 1866, he developed, within 6 months, he developed a phlebitis, and that night he wrote, "I am lost. The phlebitis which has declared itself this night leaves me no doubt that is the nature of my illness." He diagnosed malignancy is going to happen, and quite rightly, he died of CA stomach. So, obviously, this phenomenon has been around for 160 years, and now we are here talking about which is the right molecule in the treatment of this phenomenon. Just to give this is a very, very fictional character. This is not a real patient scenario. This is a lady, Mrs. Yen, 48 years, weighs about 56 kgs, receiving chemotherapeutic agent, paclitaxel group for recurrent metastatic triple-negative breast cancer. It is ER negative, PR negative, and Herceptin negative. Presents with sudden pain and swelling in the left lower limb with no breathlessness. Obviously, a first, your suspicion would be DVT, and it's confirmed by Doppler, which is a lower limb DVT on venous Doppler. The medical history includes no significant past medical history, no family history of VTE. On examination, she is not hypoxic, she is hemodynamically stable. And the laboratory findings are quite normal. And you are in a dilemma of what is the right treatment for this patient. Let's go through some scientific data to tell us which one is the right one to choose. Just to go back and recap on VT in cancer. Cancer is the highest risk in a lot of visceral malignancies, especially in pancreatic, brain, lung, hematological, and colorectal cancers. It also depends on the stage of the disease. Advanced stage, obviously, higher the risk of development of CAT. What is the time of diagnosis? Obviously, higher risk is within the first 3 months. So to say that obviously the patient doesn't develop late in the cancer, you can assume that this patient is not at the risk of developing CAT. The treatment also, which goes along with the chemotherapy, also increases the risk for thrombosis during this period, especially the type of chemotherapies you use, like chemotherapy in the form of paclitaxel group, cisplatinum groups, also some anti-angiogenic group like thalidomide for multiple myelomas. Also, if you're using erythropoiesis-inducing agents for, anemia, it also increases the risk of thrombosis. It also is, the risk is high when you're using long-standing central venous catheters in the form of port or Hickman catheter. So these are the generalized risk factors for the development of CAT. The incidence of cancer-associated thrombosis goes along. It follows a course according to the nature of the disease. If you look at the slide here, at the bottom, you see the risk of VT in a normal population. If you look at the red dotted line, is the risk of patients developing VT in the cancer population. Also, within that population, you can see that the moment the patient gets hospitalized for any illness or for surgery, for chemotherapy, there is a surge in the incidence of DVT. Again, the type of chemotherapy the patient receives, there is a peak in the development of CAT. When the patient goes into remission of the cancer, this is very clearly seen. When there is a remission of the cancer, the incidence of DVT also goes down. Also, when the patient gets, again, recurrence of the disease or a progression of the disease with the either local or metastatic disease, the incidence goes up very high, and it stays high until the death of the patient. So this is how the course of the CAT is. How high is the risk of development of CAT and what is the risk of death? It is as high as 30 times. You can see that if you don't have any VTE, if you have the reference as 1, if you have a VTE alone, the risk is about 2.6%, and if you have a cancer alone, it's about 7.4 times, and if you have a cancer and VTE, it's pretty much bad news. It's about 31 times. So that means you have to be very aggressive in prevention of DVT in these patients. If you are looking for evidence, you don't have to look so very far. In fact, these are data from the organizing committee team, the CMC, which was published quite a few years ago, in fact, more than 10 years ago, that cancer is one of the frequently associated with DVT in their own group. Here you can see that both post-operative as well as malignancy is one of the common cause of developing DVT, like 30% and 31%. Also, what are the type of malignancies they saw? Here you can see CS cervix as 31%, which is, I think the type of malignancy varies from center to center, where you're practicing, etc. In our center, the data is a little bit skewed, I would say. We see more of visceral malignancies and hematological malignancies presenting with CAT. Also, the understanding of pathogenesis of CAT has gone a long way now. Here you can see what are the various mechanisms. Predominantly, we think it's endothelial related as well as the platelet activation. So there are different molecules which is available, and if you can understand the pathogenesis, you can block the agent which is stimulating the thrombosis. Probably you have chosen the right molecule in the prevention of the disease and the treatment of the disease. So we have different guidelines, like how we have guidelines for the management of DVT and PE. Here you have American Society of Hematologists, NCCN, which is American Consortium of Cancer Network, then ASCO, American Society of Clinical Oncologists, and European Society of Cardiologists. They all go to say that in CAT, initial anticoagulation, first 5 to 10 days, rivaroxaban or apixaban can be used. LMWH is preferred over UFH or fondaparonax. Basically, you have option of LMWH or Novavax in the form of rivaroxaban or apixaban. But then, which one is the right molecule? I think I'll show you some of the data which will help you in choosing the right molecule. How did the Novavax get into this guideline? We knew that CAT still remains a challenge. LMWH does not eliminate the recurrence, like what we were talking about in the general VTE. There is a recurrence rate, and Robbie George clearly showed there's a very high incidence of recurrence in cancer. Extended therapy seems to be essential, and current therapy, if you have an LMWH, the long duration of therapy seems to be very poorly acceptable. And certainly CAT carries a substantial burden for the disease. Imagine the patient has to go through chemotherapy as well as taking LMWH on the long term. That seems to be a burden for the patient. As you know, LMWH has been the main standard of treatment for CAT. However, in spite of that, there is still a high recurrence rate, around 7 to 9% in 6 months, and for the major bleeding seems to be about 3 to 6% in 6 months. Also, the inconvenience and the cost and the poor compliance seems to be a drawback for patients who seems to be on long-term LMWH. We have had some data initially with the Einstein subset analysis, which showed that rivaroxaban was non-inferior to warfarin. Rivaroxaban to warfarin in the general population. As you know, the Einstein study, when it was designed, cancer was one of the exclusion criteria. However, it was left to the discretion of the investigators. If you think the patient can survive for more than 6 months, you can include the patient for this study. So in Einstein subset analysis, we had in the DVT analysis, 6% of the patients were in the cancer group. And in the Einstein PE, 4.7 patients were in the active cancer. Small, even though very substantial. We now have very dedicated RCTs comparing rivaroxaban to other molecules. We will go through that slowly. This is Novak phase 3 VT trials. We have rivaroxaban, as I mentioned, Einstein DVT, Einstein PE, Einstein extension. I have given the subset numbers. Here you see in the Einstein DVT, we have 207 patients with active cancer. In Einstein PE, we have 223 patients. and about 54 patients with Einstein extension all have active cancer disease. And we found that rivaroxaban was an effective modality of treatment in reducing the PE and DVT in patients with active cancer, with significant reduction in major bleeding. How is that? There was about 58% risk reduction rate and about absolute risk reduction rate of 3%, which is quite significant. And if you see the Forrester plot, it's a shift in favor of rivaroxaban in this group of patients. There are many studies now, NOACs in cancer-associated thrombosis, predominantly rivaroxaban, edoxaban, apixaban. Rivaroxaban, I can see the multiple studies. There are RCTs, there are registries, there are patient, patient complaint studies. We have RCTs in the form of Select-D extension. We have Frontline 2, which is a registry. We have Casimo, which is a patient acceptance study. Similarly, for apixaban, we have Caravaggio and Adam VTE, which are specifically designed for cancer patients. Of course, edoxaban, we have Hokusai VTE cancer study. So there are multiple studies. I have pulled in this study data as a meta-analysis, 4 studies, and which shows that again, all the randomized trials put in together, there is a shift towards NOAC. That is, all the NOACs are preferable to LMWH in reduction of VTE recurrence and complications. Also, there is reduction in the bleeding rate. I will again go into the complications bleeding in a short while. Treatment of cancer-associated VTE, there are different agents and regimens. If you are having a VKA, you should have a bridging therapy in the form of you initiate with LMWH and then start out with vitamin K. Again, if you're using edoxaban, you are starting with the LMWH and then starting out with edoxaban. However, if you're going with rivaroxaban, as Robbie George said, you can go straight away with 15 milligram twice daily for 3 weeks, followed by 20 milligram once daily. And for apixaban, 10 milligram twice daily for 1 week, followed by 5 milligram twice daily for a period of time you're looking into. But if you're going for LMWH, you're going for 200 units per kg once daily for 30 days, followed by 150 units per kg body weight subsequently, which may be about 6 months or so, which is a long period of time. Select-D is one of the investigator-initiated studies conducted in Warwick University in Birmingham. And even though it's a very well-designed study comparing rivaroxaban with thymol datilparian, which is of fragment, which is being used for LMWH, which was in usage for CAT earlier. What does the data show? Again, these are the characteristics of patients who went into this trial. They are equally differentiated between rivaroxaban and datilparian, so there is no skewing, either in the form of staging of the disease or the etiology of the cancer or the patient comorbidities. And again, it clearly showed 57% decrease in the VT reduction in this RCT. This is a 6-month follow-up study. And the VT recurrence and the major bleeding was slightly higher. Even though it's numerical, there is no statistical significance here. And that is what you're concerned about. The endpoint will be only 2, either efficacious, that is it preventing a VTE in a cancer-associated thrombosis, and then is it going to increase the bleeding, which you all know, which is a major worry in cancer patients. So what does it say? The outcome of the study, I'm going from the bottom to the top. There is no serious CNS bleeding event which was observed in either arm. So that's a good news. The incidence of fatal bleeding was similar across both the arms. Again, a good news. The incidence of major bleeding overall was low, even though slightly higher in rivaroxaban, as I said, which was not statistically significant. So rivaroxaban is a safe molecule. Again, even though the rivaroxaban and apixaban was not compared head-to-head, we are comparing the 2 studies here. That is Select-D, which was done between rivaroxaban and datilparian, and Caravaggio, which is between apixaban and datilparian. Again, you can see that the recurrent VT was prevented better by rivaroxaban than apixaban in this group. Even though in this group, apixaban had a smaller incidence of bleeding when compared to rivaroxaban, again, statistically, it was not significant. So again, when compared to LMWH as well as apixaban, rivaroxaban was going higher. These are the incidents of bleeding events in SELECT-D if you're worried about. They are divided into three types of components. One is the overall population. There are slightly higher incidents. But if you look at the upper GA cancer population, there was significant higher incidence of bleeding with this molecule, rivaroxaban. However, patients with non-upper GA group, it was same. So the IFU and the recommendation is, if you have patient with upper GA, that is esophageal, gastroesophageal, or gastric, especially a luminal malignancy, maybe you should avoid the NOVAC. You have to prefer LMWH. So this may be one of the contraindications, or maybe you should use it with caution, I guess. The baseline characteristic, again, if you see that, in SELECT-D, there is a high number of upper GA malignancies which was included when compared to Caravaggi or Hokusai. Maybe that's the reason patient had the incidence of bleeding was overall it was high. So SELECT-D included a higher proportion of patients with primary upper GI when compared to other two molecules. These are very interesting data from Mayo Clinic, which was published in Mayo Clinic Proceedings in 21, actually. Which shows that they specifically picked up patients with GA malignancies and looked at the three molecules which had higher bleeding. It is a very interesting data, but it is not taken up by any of the guideline authorities, either form of FDA or ASCO or ESC for prescribing. Here you can see that the CRNM, that is clinically relevant non-major bleeding, in total GA cancer, rivaroxaban was slightly higher when compared to apixaban. Other than that, it was the same. Patients with luminal GA cancer had significantly higher rates of major bleeding, which was mentioned to you earlier. And here you see that apixaban had a higher rate of bleeding. So the two different data we have. However, what it means is both of the molecules can have a higher incidence of bleeding with GA malignancies. Mayo Clinic study also showed that apixaban was associated with higher risk of major bleeding when compared with enoxaparin in patients with luminal GA bleeding, which was statistically significant. So the summary of the Mayo Clinic study was the rate of major bleeding in patients receiving rivaroxaban was similar between non-GA cancer, GA cancer, and luminal GA cancer bleeding. In patients receiving apixaban, the rate of major bleeding was significantly higher in apixaban group, especially with luminal GA cancer. Apixaban was associated with significantly higher risk of major bleeding compared with enoxaparin in patients with luminal GA cancer. This is in one of the observational studies. So the FDA, all the drug authorities requested for RCT before they could recommend it as a regular treatment, before they could include NOVAX as regular treatment for GA malignancies. What are the caveats for the cancer-associated thrombosis? Again, as I said, you should be very, very careful in choosing NOVAX for GA cancers. That is what the ASHS said. And NCCN also extended the caution towards GU malignancies in addition to GA malignancies, because one of the smaller studies showed higher incidence of GU bleeding in patients with NOVAX. This is a Kaplan-Meier study. The real-world study showed consistent results with rivaroxaban in CAT and low risk of recurrent VTE and similar risk of major bleeding with rivaroxaban when compared to LMWH. This is one of the real-world data we have. So basically, it also goes to prove that both the real-world data goes to prove that the recurrence of VTE is less with rivaroxaban. There's a slight or maybe equal bleeding rate with apixaban and rivaroxaban. Casimo study is one of the patient-reported treatment satisfaction form. I'll quickly run through this. It included about 505 patients. Basically, what it said was patients preferred to be on rivaroxaban when compared to LMWH for very many reasons, which is mentioned here. One of the main reasons was, one, patient has to have a long-term injection, which they don't want, along with the burden they already have with cancer. Again, the cost of therapy and the pain of the therapy, they don't want to go through it. So if you're choosing a patient for Mrs. Hen, what would you do? Probably you would choose rivaroxaban, as I said, to begin with, 15 milligram twice daily, along to follow it up with a 20 milligram once daily group. So what should be the extension therapy, as Ravi George was talking about? I think, as you know, the cancer doesn't stop at 6 months. The risk factor goes on. Again, we have quite a few data and quite a few recommendations for this. Novax, especially rivaroxaban, can be given on the long term. There is a treatment algorithm for this. Here, again, if you have a patient with no drug interactions, no high risk of bleeding, and if you don't have a patient with luminal GA or GU cancer, yes, you can go for rivaroxaban as a first choice. So it's proven to be very safe, proven to be very efficacious, very simple to use, and we have excellent data to support, very robust data and science behind this, and we have long-term experience also along with this. So you start off with 15 milligram twice daily for 3 weeks, start with 20, and then start 20 milligrams after 3 weeks for 6 months, and then you can follow it up for a long-term therapy, either 10 milligram once daily or 20 milligram once daily, depending on the activity of the cancer or the risk factor which is underlying. So the key statements are, I have to understand that CAT is an unacceptably high burden of disease. It's associated with very worse outcome, especially hospitalization, mortality. And every patient is unique, so you have to tailor a treatment along with that. And rivaroxaban is very much recommended, endorsed by various guidelines as a first line of therapy for patients with CAT. And to summarize, ladies and gentlemen, there are very many randomized clinical trials which support NOVAC, which is as effective, if not better than LMWH. Current clinical guidelines recommend the usage of NOVAX. Evidence with rivaroxaban in the real world as well as RCT in cancer patients are consistent. They have better efficacy and safety profile. And Cosimo has an increase in treatment satisfaction that persisted in those that continued with therapy. Thank you. Thank you very much. Ilay Kumar is the only person, is it, asking questions for all the presenters.
Thank you, sir. Enjoyed your talk thoroughly. Sir, the guidelines are very clear about how long to continue. As long as active cancer is there, you need to remove drugs.
Yeah, that is always a question here and debate. Yes, as long as a patient has got active cancer, and as long as the patient is on risky chemotherapy also, just because patient is in remission clinically, and sometimes patients are on chemotherapy drugs which are very, very thrombotic inducing drugs, so you have to be careful with that also.
Yes. And if you remember, a few years back, not a few years, some time back, Professor Kakkar Jr. gave a lecture.
AJ
Yes,
Kakkar.
on survival benefits of cancer patients who are on LMWH. That is a fragment, exactly. So does our NOVAX offer this survival benefit?
Right. See, obviously, none of the studies have looked into it. In fact, maybe, see, this is a very old study, what you're quoting, Ajay Kakkar, is a very old study, more than 20 years ago.
Yes.
Maybe the survival benefit was preventing DVT and PE those days. May not be active cancer disease. But I think, as you know, this study is only about 4 years, 5 years old. And as you mentioned, somebody mentioned, we don't even know the long term. Maybe only 2 years or so we have a long-term study. So maybe in future, I think we'll have some data on that, I think.
Thank you, sir.
Thank you. Yes, Edwin.
Balaji, thank you. Thank you, Robbie. Any one of you can field this question. I loved your slide about predisposing and the exposing factors. So just want to know what's your policy or algorithm. You have a gentleman or a patient who's come in, malignancy, central line-induced thrombosis, lines are a problem. What would you do? Needs anticoagulation? Leave the line in, take it out when job is done, or take it out, find another line?
Right. Okay. See, certainly, you are talking about Hickman and Ports, is it? Or okay. We try to anticoagulate these patients. It depends on whether you are talking about port occlusion or just DVT. We just anticoagulate them. We just anticoagulate them depending on, see, by and large, we can go in for rivaroxaban now with the available data. Of course, olden days, we always gave LMWS as a bridging therapy and then switched over to VKA. Now with available data, that is what we do now. Secondly, if you have line-induced thrombosis, you have to start off with the thrombolysis, line thrombolysis or catheter thrombolysis, and then you can start off with anticoagulation. That we have used. Both Hickman as well as port thrombolysis, we have used that.
Thank you.
Because keeping the line in seems to be very, very important for these patients to go on with your chemotherapy. Right, if no further questions, thank you very much. Thank you.